श्रीनिवास सर को अच्छा आता है कनाडा।
Okay, sir.
हमको जो Aditya, let us know when to start, okay?
Yes, sir. Yes. Yes, start, sir. Now we are live.
Okay, thank you.
Darshan, we can proceed.
Okay, sir. Good morning, everyone. I am Dr. Darshan, a senior resident pursuing DM Critical Care Medicine from AIMS Jodhpur. The topic for today's discussion is evidence-based management of gram-negative infections in ICU. The moderator for today's presentation is Dr. Gansham sir, Academic Director X and General Secretary of ISCCM. So today we are going to discuss mainly about the two class of drugs, that is organisms, that is lactose fermenters and non-lactose fermenters. The lactose fermenters such as E. coli and Klebsiella, non-lactose fermenters such as Acinetobacter and Pseudomonas. So this picture, it depicts the geographical divide of the antibiogram in the various regions. The Western guidelines are mainly based upon the KPC organisms because KPCs are predominant in those parts of the world. Whereas in the Indian scenario, it is the NDM which predominates. So we need to consider into account the local antibiogram before managing such infections. So this is the burden of the disease that we are facing right now. The Acinetobacter, this is the Indian data. Acinetobacter is almost 91% resistant to carbapenems, where Pseudomonas is 43% resistant and Klebsiella has only 30 to 35% susceptibility left. This was a study conducted in Indian scenario. This is the ICONIC 2 study. It is the consensus on the management of carbapenem-resistant enterobacterial infection in critically ill patients. As you can see, the predominant organisms were NDM, OXA48-like mechanism resistance. The other resistance, such as KPC, was uncommon in the Indian scenario. So, what is the iceberg of resistance? So we all miss the typical genotypic and mechanisms of resistance. We mainly look into the phenotype, that is the antibiogram, whether the organism is sensitive or resistant to a particular antibiotic. But we also need to look into the fact that whether the organism produces KPC, NDM or OXA48, or whether the MIC has increased, which decreases its cidal activity. So what is DTR, that is difficult to treat resistance? This is the emerging concept, that is non-susceptibility to all first-line agents, that is beta-lactams, fluoroquinolones, that leads to higher mortality. The 2024 IDSA guidelines, it prioritizes the use of novel BL-BLI inhibitors over the older agents for DTR pathogens. The emerging concept is DTR index. So it is based on the availability of drug in a specific region. So according to that, DTR index is calculated. What are the escape pathogens and why is it important to know about these pathogens? So in the community, it is mainly the E. coli which causes infection, that is uncomplicated UTI or intra-abdominal infections. But when it comes to a ICU, there is a spectral shift from E. coli, that is the fermenters, to the non-fermenters, that is Acinetobacter and Pseudomonas. These are frequent infection. These are the frequent organisms which cause VAP in these patients. Now coming to the inoculum effect. The inoculum effect is that in the presence of high bacterial load, the antibiotic fails to provide the adequate recovery, that is in cases of abscesses where the bacterial load is very high, the antibiotics fail. Now coming to the gram-negative cell wall, It mainly consists of the defensive triad, that is the outer membrane, penicillin binding proteins, and the enzymes. It is like an armored tank. So in order to kill it, we must breach the outer cell wall, survive the enzymes in the periplasm, and then bind to the penicillin binding protein. That is the target for antibiotics. So this is a pictorial representation of gram-negative and gram-positive cell wall. As you can see, the gram-positive lacks the outer membrane, whereas gram-negative has the outer membrane with the peptidoglycan chains. Next, we'll discuss about what are the mechanisms of resistance in these organisms. It can be mainly divided into two, that is intrinsic resistance and the acquired resistance. The acquired resistance mainly occurs because of the drug uptake limitation, that is porine mediated, or due to the presence of efflux pumps, or it can be drug inactivation by enzymes such as beta lactamases. It can also occur by the drug target modification. Now let's see what are the intrinsic resistance we can see in these organisms. The E. coli is intrinsically resistant to macrolides. Klebsiella is intrinsically resistant to ampicillin. Acinetobacter is intrinsically resistant to ampicillin and aztreonam. Pseudomonas is intrinsically resistant to tetracycline, first and second generation cephalosporins. Next, we'll be seeing what is the Ambler classification for these beta lactamases. It can be broadly divided into four classes. That is class A. It includes serine-based enzymes. Those are KPC, CTXM, SHV, and TEM. The class B are mainly zinc-based. These are the metallo-beta lactamases, the NDM, BIM, and IMP. These are the most notorious ones in the Indian scenario. The class C are AMC, and class D are OXA group of enzymes, that is OXA 48, OXA 23, and OXA 51. So as we had discussed, one of the mechanisms of resistance was modification of the target site, that is penicillin binding protein. It mainly occurs in gram-positive organisms, but it is also a crucial mechanism of resistance in Acinetobacter. The aztreonam resistance often stems from the penicillin binding protein alterations. The colistin resistance, as we can see, it occurs by plasmid mediated resistance, that is the MCR1. It can also jump between two bacteria. The other mechanism by which resistance can occur is biofilm formation. The MICs in the biofilm are almost 1,000 times greater than that of the other sites. The biofilm in the CVCs, central venous catheters, and other catheters, they are virtually untouchable. The only way to treat these infections are removal of the lines and initiating appropriate antibiotic therapy. Now let's see what is heteroresistance. A particular bacteria, it might have a sensitive colony and also a resistant subclone. So the lab, it mainly tests the majority. But if 1 in a million bacteria is resistant, that subclone will outgrow under pressure. And this is the main reason for treatment failures, even if the organism was sensitive in vitro. Why do we need to know about the mechanisms of resistance? It is mainly to dictate the drug choice, whether it is enzymatic or non-enzymatic mechanism. The enzymes, these can be inhibited, but the porins, efflux pumps, they usually require higher doses or different antibiotics. So the mechanism matters. So this is an overview of carbapenem resistance detection and characterization in gram-negative organisms. So next, coming on to diagnostics and stewardship. So we have seen what are the mechanisms of resistance. So how do you diagnose the infection? It is mainly done by standard cultures, which takes about 72 hours, or it can be done with PCR based techniques. which takes only 2 hours, and other molecular platforms such as BioFire, Cepheid, genotypic detection, which detects the KPCs, NDM, OXA, VIM genes directly from the sample. So these are the pictorial representation of the few of the molecular diagnostic techniques which we have discussed. The main ones, as you can see, are CARBA NP, NG test CARBA, Expert CARBA, BioFire film assay, and the IPLEX MBL ID. These are few rapid diagnostic tests which can be used for diagnosis of the infections. The phenotypic rapid test, that is the CARBA NP, it confirms the carbapenem's activity quickly and it is cheap. It can be used in the hospitals for quick diagnosis and rapid initiation of antibiotic therapy. The MALDI-TOF MS, that is matrix-assisted laser desorption, ionization, time of flight, mass spectrometry. It mainly identifies the organisms in minutes after the culture growth. It gives us the name immediately so that we can change the empiric choice instantly. So how do you interpret the antibiogram? So it is mainly by seeing whether the organism is sensitive or resistant. And based on the MIC, we can decide on which antibiotic to initiate. There is a concept called as MIC creep. It means that there is gradual and steady increase in the MIC of an antibiotic for a particular bacterial population over the time, while still they are in the susceptible range. So considering an MIC of 1 is better than MIC of 4, even if the both are sensitive to that antibiotic. So what are the breakpoints should we consider? We usually consider the CLSI or the UCAST criteria. So whatever that is susceptible in USA, it might be resistant in Asia or Europe. The UCAST guidelines or the breakpoints are generally stricter. Bacteria that might be sensitive by CLSI might be resistant by UCAST. So the clinical failure mainly lies in this gap. Now coming to the utilization of procalcitonin in any infections or sepsis. The procalcitonin should be used only to de-escalate and stop the therapy and not diagnose or initiating the therapy. So you should have a de-escalation strategy in mind while initiating the antibiotics. You should start initially with broad spectrum antibiotics, narrow it fast to prevent the resistance. Once we have the sensitivity, we should drop the double coverage and switch to targeted therapy. So this is the annual report of surveillance and antimicrobial resistance by the ICMR. It was last year's data which they presented. In this, they say that the gram-negative organisms are most common pathogens which are isolated from most of the samples. In those gram-negative bacteria, Acinetobacter, Klebsiella, and Pseudomonas constituted about 80% of the causative pathogens for VAP. So coming to enterobacterials, this is the data of ICMR for the 2024. In enterobacterials, E. coli has showed increased susceptibility to ceftazidime from 19.2% to 27.5%, but there was a significant decline in susceptibility for carbapenems. As you can see here, it is about 62.9% in 2024. For Klebsiella pneumonia, it showed reduced susceptibility, notably to piptas and carbapenems. It has gone down from 48% in 2017 to 35% in 2024. The TEM gene was the most predominant gene, present in 30% of the E. coli, followed by IMP, VIM, NDM. The AMC beta lactamases were least prevalent. In case of Klebsiella pneumonia isolates, TEM gene was the predominant gene, followed by OXA and SHV, whereas AMC beta-lactamases were least prevalent. Among the enterobacterials, E. coli was the predominant pathogen isolated from the urine samples, but they were sensitive to nitrofurantoin and fosfomycin. A decent percentage of these isolates are only OXA48 producers, which can be treated with BL-BLI combinations. The MBLs, that is the metallo-beta-lactamases, or in combination with OXA48 like carbapenemase, they require Astenom avibactam or polymyxin based combination therapy. This was about the lactose fermenting group. Now coming to the non-lactose fermenting gram-negative bacteria. There was a gradual increase in carbapenem resistance for Pseudomonas from 26% in 2017 to almost 38% in 2020. Fluoroquinolones such as ciprofloxacin showed a susceptibility rate of 57% in 2017, and it has increased to 57% in 2024. The molecular profile of carbapenem resistance in Pseudomonas was predominantly driven by the MBL genes, particularly the NDM and the VIM. In case of Acinetobacter, the resistance to meropenem was recorded to be 91%, which limits our treatment abilities. So similar to previous years, OXA23 was the predominant carbapenemase in Acinetobacter, with rapidly expanding integration of NDM, often in co-carriage. These two together present, it amplifies the resistant potential of the Acinetobacter. So what is the clinical relevance of all these data? As you can see, Pseudomonas for MBL producing strains, a combination of Astenom with Cephta or Astenom avibactam, it provides the effective strategy, particularly for the co-producers. And cefdorocol may be considered if in vitro susceptibility is confirmed. The susceptibility of Acinetobacter to minocycline was close to 70%, making it the most effective antibiotic after colistin. In case of Acinetobacter, the combination regimens involving colistin and polymyxin with minocycline or high-dose ampicillbactam, it may be considered as salvage approaches in most of the settings. The cefdorocol can be used against OXA and NDM producing Acinetobacter, while sulbactam durlobactam may provide excellent activity against OXA type of carbapenemases. Now coming to PKPD optimization. The time about the MIC concept. What is time about the MIC concept? It is maximizing the time about the MIC, which is the main goal of antibiotic therapy in these cases. The peak concentration for meropenem does not matter. The duration matters. That is, we need to stay above the MIC for at least 40 to 70% of the time. So what we can consider is extended infusions of antibiotics, such as infusing meropenem over 3 hours. It doubles the target attainment. Next, we'll see about the augmented renal clearance. Augmented renal clearance is the one where there is increased solute clearance with the creat clearance of more than 130. So this is basically seen in cases of sepsis and septic shock. So which are the drugs that have augmented renal clearance? It is mainly the hydrophilic drugs that are affected because they are primarily eliminated by renal. So the drugs are beta-lactams, glycopeptides, aminoglycosides. So these, the thing we should consider is while dosing these drugs, we should keep in mind that they have augmented renal clearance. What should we do when there is renal failure? We should not reduce the loading dose. While patients undergoing CRRT, it removes the antibiotic efficiently, so the dosing should be kept similar to a normal functioning kidney. So next we'll see about the tissue penetration of various antibiotics. Drugs such as tigecycline, polymyxins, they have poor lung penetration, but beta-lactams are reliable in case of lung infections. Why should we consider volume of distribution in sepsis patient? Because the septic patients have third space fluid accumulation. The hydrophilic antibiotics, they dilute in those fluid and they need higher concentration of antibiotics in order to be effective. Let's see about the aminoglycoside pharmacodynamics. The once daily dosing, it maximizes the bactericidal activity and minimizes the toxicity. Because the aminoglycosides are concentration dependent as compared to the beta lactams. Giving a loading dose, it neutralizes the bacteria. So in order to achieve all these things, whether it is a time dependent killing or a concentration dependent killing, we need to consider therapeutic drug monitoring. It allows us to tailor the dose exactly to the patient's clearance. Nowadays, we are using beta lactams therapeutic drug monitoring in order to maintain appropriate level of those antibiotics. Next, we'll see the enterobacteriaceae, that is the ESBL and the AMC producing enterobacteriaceae. For ESBL bacteremia, carbapenems are the drug of choice. The Merino trial, which was a landmark trial conducted, showed that piperacillin tazobactam was inferior to meropenem in ESBL bacteremia. In case of ESBL urinary tract infections, aminoglycosides, nitrofurantoin, or piperacillin tazobactam can be used. So what are the space organisms? That is the Serratia, Pseudomonas, Acinetobacter, Citrobacter, Enterobacter. All these act by inducible resistance mechanisms. That is, the exposure to ceftriaxone, it selects for the resistant mutants. So the drug of choice in these patients can be cefepime. Cefepime, it is stable against the AMC hydrolysis. The drugs we should be avoiding are ceftriaxone and ceftazidime, that is the third generation cephalosporins, because they are the potent signals for bacteria to ramp up the resistance. So what about piperacillin tazobactam for AMC producing organisms? The tazobactam, it does not inhibit AMC well, so it should be avoided in severe sepsis. So how does ESBL and AMC compare? ESBLs, they often respond to carbapenems or sometimes combination with inhibitors. The AMC producing infections, they require carefully selected agents like cefepime or carbapenems, as they can cause resistance with third generation cephalosporins. Now coming into the CRE, that is the carbapenem resistant enterobacteriaceae. The mortality in these patients without therapy is about 40 to 50%. The first line for KPC or OXA48 is ceftazidime avibactam. The other potent agent against KPC are meropenem vaborbactam, but it is not active against OXA48 and NDM. The imipenem relebactam, they are similar to meropenem vaborbactam, but it adds the anti-pseudomonal activity. So what about the NDM? The metallo-beta-lactamases. In India, this accounts to about 60 to 70% of our CRE. None of the above drugs we discussed, that is ceftazidime avibactam, meropenem vaborbactam, imipenem relebactam, work in these organisms. So the drugs that works wonder is the Asteonam. Asteonam is not hydrolyzed by the NDM group of beta-lactamases. So we need to test the synergy of ceftazidime avibactam with Asteonam before initiating the therapy. How does it act? Avibactam, it inhibits the ESBLs and AMCs, which would otherwise destroy the Asteonam, and whereas Asteonam, it kills the NDM. So currently, this is the standard of care for NDM group of organisms. Next, coming to ceftriaxone. So what is the mechanism by which it acts? It uses the iron transport channels to bypass the porins. The antibiotic, it binds to iron and the bacteria pulls the iron along with the drug inside. So it bypasses the mutated porins entirely. It is active against all the KPCs, NDM, OXA, and Pseudomonas. But there is a catch in that. There is a study called Credible CR trial, which showed high mortality in Acinetobacter subgroup. So it had higher mortality in the ceftriaxone arm for Acinetobacter. It might be because of the worse baseline status, but we should be cautious while using this drug. So coming to the polymyxins. So polymyxins are used as a last line in case of treating these infections. These are mainly toxic and low in efficacy. So how does the polymyxin and colistin compare with each other? Colistin is a prodrug. It should be converted into the active form inside the body, whereas polymyxin is an active form and it has rapid onset of action. For UTIs, colistin acquires high urinary excretion, so it is most preferred. Both have nephrotoxicity risk, so we should be careful while choosing these drugs. Now coming to tigecycline. The eye tissue level, it achieves eye tissue levels, but it is not useful for bacteremia. High dose tigecycline, that is 200 followed by 100 BD, can be used for MDR organisms. There was a recent study in British Journal for efficacy of high-dose tigecycline containing regimens for the combination of treatment of CRE bacteremia. It concluded that high-dose tigecycline was associated with improved microbiological clearance and showed a trend towards decreased mortality in patients with CRE bacteremia. So this was about the fermenters. So what about the non-fermenters, that is Pseudomonas and Acinetobacter? In these organisms, ceftolozane tazobactam can be used, but it is not active against KPC NDM, but potent against Pseudomonas, where there is efflux or porin loss is the mechanism of resistance. The next organism we are going to discuss is Acinetobacter, that is carbapenem resistant Acinetobacter. It is often resistant to all the beta lactams. It combines every resistance mechanisms that is known to us. The drug of choice in these cases is sulbactam, that is in combination with durlobactam or in combination with polymyxin. Sulbactam has direct bactericidal activity against Acinetobacter. The combination of sulbactam and durlobactam, it protects the sulbactam from degradation. So it is considered as the first line for treatment of crab infections. In our scenario, we mainly use polysulbactam as the first line for crab infections. The other combination therapy that can be used for crab are high dose ampicillin sulbactam with minocycline or polymyxin. Minocycline, it has excellent coverage for VAP and it is different from tigecycline. The next organism we are going to discuss is a bit about Stenotrophomonas and Burkholderia. The Stenotrophomonas maltophilia, it is intrinsically resistant to carbapenems. So in these organisms, the drug of choice is cotrimoxazole. If they are allergic to sulfa or the bacteria is resistant, we can also consider levofloxacin or minocycline. Finally, we can also consider ceftriaxone in these patients. Coming to Burkholderia, these are intrinsically resistant to polymyxins, aminoglycosides, and phosphomycin. The dreaded complication of Burkholderia is septicemia syndrome, which is a necrotizing pneumonia, uncontrolled fever, and bacteremia. The drug of choice for Burkholderia is trimethoprim sulfamethoxazole. The other drugs which can be used is ceftazidime and meropenem. So we discussed about what therapy we should be using in a particular group of organisms producing a particular gene or particular mechanism of resistance. So we'll see about the duration of therapy we need to treat those patients for. In case of ventilator-associated pneumonia or hospital-acquired pneumonia, the duration of therapy should be for about 7 to 10 days. In cases of complicated UTI, it should be about 10 days. For catheter-related UTI, it should be about 5 to 7 days. For intra-abdominal infections, it is 4 to 7 days. For central line-associated bloodstream infections, it is 10 days. So this is the data we had discussed earlier about the resistant patterns. That is, Acinetobacter is almost 91% resistant to meropenem, whereas Klebsiella is about 70% resistant, and Pseudomonas is 43% resistant to the carbapenems. So we'll see what are the recent studies in the major published in the major journals on these drugs and group of organisms. This was ATTACK trial. It is on the efficacy and safety of Darlobactam versus colistin for the treatment of serious infections caused by Acinetobacter. It was published in Lancet. It stated that Sulbactam, Darlobactam, it was non-inferior to colistin, and both agents when combined with imipenem cilastatin for primary endpoint of 28-day all-cause mortality. So it can be used as an effective intervention to reduce the mortality from serious infection caused by Acinetobacter group of organisms. This was another trial which was published in Lancet, that is the Aspect NP trial. It is the ceftolozane tazobactam versus meropenem for the treatment of nosocomial pneumonia. It concluded that high-dose ceftolozane tazobactam is an efficacious agent against the gram-negative nosocomial pneumonia, mainly in the ventilated and critically ill patients. This was the revisit trial, which was on the Astronom avibactam versus the meropenem for the treatment of gram-negative bacteremia. This study, it provides the support for Astronom avibactam as a potential therapeutic option for complicated intra-abdominal infections, HAB, VAB, which was caused by gram-negative organisms. This was a study published in JAMA. This is the landmark Marino trial, which studied the effect of piperacillin tazobactam versus the meropenem on the 30-day mortality for patients with E. coli or Klebsiella pneumonia bloodstream infections and ceftriaxone resistant. So it stated that among the patients with E. coli or Klebsiella pneumonia with the ceftriaxone resistant, the definitive treatment with piptas compared with meropenem, it did not result in a non-inferior 30-day mortality. So it do not support the use of piptas in these settings. So this was the conclusion of the ICONIC 2 trial, which was conducted in Indian scenario. It validated the molecular tests for resistance mechanisms in conjunction with the phenotypic tests. The phenotypic resistance to ceftazidime avibactam, it should trigger the synergy testing for ceftazidime avibactam with the Astronom, particularly in critically ill patients. So the synergy testing should be routinely performed for CRE organisms in critically ill patients. So we saw what all the organisms that cause these infections and the mechanisms of resistance and the studies which have been conducted in these organisms. So we'll finally summarize what needs to be, how it should be treated. So for CRAB, that is the carbapenem resistant Acinetobacter, the new IDSA guideline states that sulbactam durlobactam is the drug of choice. In our scenario, it is polymyxin sulbactam. In for DTR pseudomonas, it is ceftolozane tazobactam or imipenem rilabactam. For MDL Klebsiella, which is NDM producing, the combination of cefta avi with the Astronom or the cefdurocol can be used. For ESBL producing E. coli, carbapenems, that is the meropenem, is the drug of choice. So what are the future directions? What are the newer pipeline agents? The inhaled antibiotics have been used for quite some time now. These attain higher concentration locally. They can be used as an adjunct in cases of MDR-VAP, but as not as a systemic therapy. It should not be used as a monotherapy as well. The main pipeline agents that are in line are Zidibactam. The Zidibactam cefepime, it has shown some promise against the NDM producing organisms, whereas cefepime taniborbactam, they inhibit both the serine as well as the metalloenzymes. It is exciting. Taniborbactam is an exciting choice because it might be the first inhibitor to block both KPC as well as NDM. It might be a potential monotherapy for future. So we saw all the organisms and the future directions which we can go, but main thing we should keep in mind is we should always be thinking of preventing the resistance, development of resistance. So how can we do that? It is by optimal antimicrobial stewardship strategy. The first step in this is to stratify the risk, control the source, use rapid diagnostic techniques, and optimize the dose using the PK/PD principles, therapeutic drug monitoring, adjusting for renal or hepatic function. Then mainly consider de-escalation. De-escalation by switching to narrow spectrum, shortening the duration of therapy, and stop the antibiotics when appropriate. There should be a continuous reevaluation and monitoring in these cases. So the thing we should remember is we have to steward our way out in order to prevent the further resistance to occur. Thank you.
Thank you, Darshan. No, you have taken us through the various aspects of managing resistant gram-negative bacterial infections. No, in a very crisp and simpler way to understand and to kind of implement it at the bedside. Just a couple of thoughts. I think one of the keys in managing these infections is to identify the resistance patterns. For a long time, we were giving therapies empirically, but I think as days goes by, it becomes more and more difficult, and there's a higher chance that there could be a clinical fail when you go and treat potential hospital-acquired infections without having a knowledge about the resistant genes and resistant patterns. Second thing that we all should do where we don't have advanced facilities is get in touch with your microbiology lab and at least ask them to give us the first steps, the first identification of whether you are dealing with a lactose fermenter or a non-lactose fermenter. So that will kind of help you in choosing your initial strategy. Right? We know that if it's a lactose fermenter, then maybe the combination of Cefta IV, if your ICU has a very high incidence of carbapenem resistance, and if it's not, then maybe choosing for a polymyxin based therapy could be the initial strategy. Third thing is about the rise of PBP3 mutations, especially for E. coli. We are seeing more and more resistance to E. coli against both Cefta IV is also showing resistance to E. coli. That is because of the PBP3 mutations that are being on the rise. So in such situations, a good combination or good agent to add would be either plasmamycin or phosphomycin. So just keep that in mind. So thank you once again. Srinivas, your thoughts?
Yeah, thank you, Darshan. It was a crisp review. Just a couple of points we should understand and remember. The use of molecular diagnostics, the rapid diagnostic test has probably added to the confusion and to the load of resistant bugs we are treating. Whatever is isolated need not be the pathogen. Whatever may be the pathogen may not always be isolated. And whatever is isolated need not always be treated. This is something, is a dictum which we should remember. Ultimately, we have to go back and look at what is the pathophysiological process, what is the presentation, in what context a particular sample has been taken. For example, you have a patient with respiratory infection and ARDS. Patient has not woken up, and then you do an LP. You find some exotic virus in the CSF. You don't go chasing treating that virus. Same thing happens to the so-called resistant bugs, which are quite often thrown up on the molecular diagnostics. The second aspect is we have to have greater access to MALDI-TOF. MALDI-TOF is something which gives us very reliable resistant patterns within a positive culture sample. It is probably something which, I mean, Hyderabad has two machines, but over a period of time, I think more such availability of MALDI-TOF is something that is uh, probably going to change. Third point, with the introduction of the standalone Avibactam Aztreonam combination by Pfizer, I think more clarity is needed. So whether a combination of polymyxin B with a combination of Aztreonam and Avibactam can be a better combination than ceftazidime Avibactam Aztreonam combination is something we need to look at prospectively in our patients. The last month or so we have used in a few patients, and I personally feel it's a better combination than ceftazidime Avibactam. The last point, which we cannot get away from, is the artificial intelligence. Artificial intelligence driven platforms seem to be picking up resistant patterns, seem to be telling you that you are more like, if you have a reliable antibiogram of 3-4 years in your city with a good number of samples, an artificial intelligence based algorithm is going to predict if you have a patient who's got a respiratory infection acquired in the hospital. It's going to tell you what are the more likely organisms, what are the more likely resistant patterns, which drugs are more likely to be effective, and what is the combination that is more likely to be effective. So the advent of AI will actually probably give some sense and purpose into, especially agentic AI. It will actually tell you what antibiotics to prescribe. That's maybe a game changer as far as management of both resistant gram-positive and gram-negative infections is concerned. But that it was a very good and crisp review. It was very concise, but it was very informative to all those who are listening.
Thank you, sir. Thank you for the opportunity, sir.
Thank you, Darshan, and wish you the very best of luck. And
Thank you, sir.
for all of our listeners, we are very, very near to the Cricket 2026 at Chennai. If you have not registered, don't miss this opportunity. Please go and register now. Thank you very much, and we'll see you next week. Thank you, Darshan.
Thank you, sir.